right. Thank you for that introduction, and thank you for letting me talk today. My title's a little different than what your brochure. We're going to talk about shock in the pediatric trauma patient. Goals and objectives. We're going to spend most of our time talking about hemorrhagic shock in the pediatric patient. We're going to talk about how children are unique, and then we'll talk a little bit about neurogenic and obstructive shock at the end. Why are we talking about this? Why is this important? In kids, trauma is the leading cause of death and disability. Firearm injuries surpassed motor vehicle collisions in 2019 as the leading cause of death in children. And as we know, as first responders, we are the integral part of caring for these children. We talk about that golden hour, the golden hour that you in the field start with, the golden hour that me in the emergency department continue. So what is shock? It is cardiovascular dysfunction. It is where the circulatory system is unable to provide the oxygen and the nutrients that the body needs to be able to function. As I was telling my dad about the lecture that I was giving, he remembered somebody in medical school said, shock is the pit stop on the highway to death. This definition, if you notice, does not mention vital signs. There are a lot of types of shock. Hypovolemic, where you have lack of circulatory volume. Neurogenic, where the nervous system disruption, you lose your stimulation to the sympathetic nervous system. Cardiogenic shock, where your pump is failing. Obstructive shock, where you actually have a mechanical obstruction to the outflow of the heart. And then distributive shock, which is inappropriate vasodilation. On the trauma side of things, hypovolemic shock is usually hemorrhagic shock. Neurogenic shock is a spinal cord injury. And then obstructive shock, we will see tension pneumothorax and cardiac tamponade. So again, I said I was going to spend most of my time talking about hemorrhagic shock. So the definition of a massive hemorrhage is bleeding requiring 40 cc's per kilo in kids, or 10 units of blood in a 24-hour period. And between 5 and 15% of pediatric trauma patients will actually meet this criteria. Pediatric blood volume, just like everything else in kids, changes with age, and that's what makes pediatrics challenging. So your blood volume in a premature infant can be between 90 to 100 cc's per kilo, and as we get older, our blood volume stabilizes to more of the adult blood volume. So we talk about massive hemorrhage. How does this happen? Well, you disrupt a blood vessel. We see it a lot in penetrating trauma, and certainly as we saw from the statistics from NOTS, at least in Northeast Ohio, are penetrating trauma, and that includes in pediatrics, is on the rise. We also will see a massive hemorrhage with blunt trauma. And then the other part of it is that you disrupt the whole coagulation cascade. And so your platelets are not functioning well, your fibrinolysis is not functioning well, and so you have injury to vessels, plus you have clotting factors that aren't wanting to do what they're supposed to be doing. In kids, heart rate and blood pressure and respiratory rate are neither sensitive nor specific for hemorrhagic shock. You can't hang your hat on vital signs in kids to determine if they are in shock or not. A young, healthy patient can lose up to 30% of their blood volume and have mostly normal vital signs. And I took this table from Up to Date. If you look at what class 2 hemorrhagic shock is, it's 15 to 30% blood volume. And in children, you will see mild tachycardia, mild tachypnea, and mildly anxious. And I would argue that that's probably every pediatric trauma patient that we get. They're scared, they're in pain, they're separated from their loved one, their caregivers, they are strapped down to a backboard, they are in my trauma bay where everybody's got masks and gowns on and staring down at them. And so mild tachycardia, mild tachypnea, mildly anxious could just be a normal kid. And so what we need to do is figure out how to decide what is really shock and what is just a normal kid. So we're going to talk a little bit about shock metrics. There's a lot of scores that are out there now. In adults, we have the shock index, which is fairly straightforward. It's heart rate divided by blood pressure. Of course, with kids, vital signs change for age, and so we have the SIPA, or the shock index, which is pediatric adjusted. And you have a whole list of what the normal range of a heart rate, the normal range of a blood pressure, and then what the appropriate SIPA cutoff values are. And again, this can be challenging when you're trying to do this in the field. If you have an app, if you have something where you plug in your vital signs and it can crank something out, that can be helpful. There's a lot of studies. SIPA is probably the oldest of the pediatric shock scores that's out there. So there's a lot of studies. There's pre-hospital studies that look at the pre-hospital SIPA score versus what we get in the emergency department. There's studies that looked at, can we use your SIPA score to activate your activation criteria in the emergency department? And even if we have a little over triage, it still falls into what is acceptable by the American College of Surgeons. And then there's always the question, well, can the SIPA score help predict who needs a blood transfusion? And what we have seen from several studies is that it's actually the trend over time. One SIPA score might not mean anything, but if it's abnormal in the field, it's abnormal in the emergency department, it's abnormal over time in the emergency department, that may be a better predictor. Recent systematic view was published looking at just straight old forward systolic blood pressure, looking at the adult shock index, looking at the pediatric age-adjusted shock index, and the pediatric adjusted one is obviously discriminates best for the severely injured kids. It has more value when it's trended over time. It is associated in this systematic review with a greater need for blood, and it's associated with a higher in-hospital mortality. Some other numbers have come out. The RSIG, which is the reverse shock index times the Glasgow Coma score. This one, there was a single center study, and an abnormality in this had a higher rate of intubation, ICP monitoring, blood, ICU admission, laparotomy. And then something that's probably the best validated for research, but is not very practical for us in the ER in the field, is the pediatric shock index and the rapid pediatric shock index. These were actually derived and then validated, and they have a higher positive predictive value and a similar negative predictive value. But again, these are much more complex calculations and are probably better more in the research setting. The management, first and foremost, is stop the bleeding, including tourniquet use. You can use a tourniquet in a child. There is the shock, hemorrhagic shock collaboration that had a publication out, recommendations. Go ahead and use your tourniquet. Your Cat 2 tourniquets might be too big for some littler kids, but if you have a little kid who potentially has an open wound and is hemorrhaging, you can use, I had a 1-year-old, and several IV tourniquets were applied to use as tourniquets. There's also the stretchy band ones that can be used in the smaller kids. You want to get good vascular access, and of course, the sicker the kid, the harder to get vascular access. More proximal, the better. If you can get an IV, fabulous. If you can't get an IV, jump to your IO. Again, we need access to resuscitate these kids. Start with your crystalloid. You can do saline or ringers, 20 cc's per kilo. If you're in the field or if you're in your emergency department, use your Broslow tape. Get a best estimate of what this kid's weight is and 20 cc's per kilo. But the question is, how early should we be jumping to blood in kids? And this was a really good study published in 2020. It was a prospective observational study looking at the timing of crystalloid versus early blood products. 712 patients, what they found was that with every crystalloid, so every saline or Ringer's bolus after the first one, it was associated with incrementally greater odds of extended ventilator, intensive care, and hospital stay. And so from this study, there's a recommendation for the early use of blood products, and acknowledging that, yes, in kids, it's hard to tell who needs blood. But the bottom line with this study is we shouldn't be drowning our kids in normal saline. We should be using age-based, or weight-based dosing, and not filling them with 3 liters of saline, but switching to blood quickly. So the pediatric hemorrhagic shock consensus had an extensive bunch of publications that came out in early 2022, and the summary statement, one of the summary statements from this article is that in traumatically injured children in hemorrhagic shock, we suggest prioritizing blood products over crystalloid in resuscitation. Another study that came out and published in the same journal talked about time as tissue, barriers to timely transfusion, and really looked at why are we not transfusing these kids as quickly as the literature and the consensus statements are saying that we need to. So in order to control hemorrhage, you have to, first of all, decide. You have to recognize and decide and to pursue the hemorrhage control. Dispense is number 2. You have to obtain the blood products and all of the other adjuncts and actually physically get them to the bedside. And then 3 is delivery. You have to give them, and we've recognized that there are barriers to all 3. So kids' amazing ability to compensate and hold on to those vital signs delays recognition of who's actually in hemorrhagic shock. There's the provider inexperience of recognizing shock, and there's a cognitive bias that we don't want to give kids blood products too soon or contaminate them or anything like that. Dispensing, blood products have a shorter shelf life, and it depends on where your blood is in relation to where your bleeding patient is. Do you have blood in your emergency department? Does it have to come from the blood bank? How far away is your blood bank from your emergency department? We actually simulated this at Rainbow and found that to run and get our massive transfusion cooler and come back took 14 minutes, and that was with somebody moving fast. And then delivery. Kids are hard to get IVs in, especially if they're in shock, especially if they're clamped down. There might be inexperience using rapid infusers, and yes, we can use rapid infusers in children. Or alternative access models, push-pull techniques, anything like that. And again, another part with cognitive bias. So we need to take all of this into consideration when we're deciding if a child is in hemorrhagic shock. In addition to damaging the blood vessel, we have disruption of coagulation, which then just sends us down a rabbit hole. So tissue injury triggers that clotting cascade to keep going and going and going and using up all of those clotting factors. Furthermore, if you're not perfusing your tissues very well, you stimulate the endothelium to release factors that actually lead to increased clot breakdown. So you've got clotting factors that are being used up. You have injured tissue secreting clotting factors that are preventing clotting. And all of this is happening at the same time. And most folks have seen this triad of coagulopathy, hypothermia, and acidosis. In the field, you can do your best with hypothermia. In my trauma bay, I can get it to a balmy 85 degrees, and I can get bear hugger, but in the field, it's blankets, it's warm packs, it's whatever you can do to help keep these kids warm. Coagulopathy, we need to address not drowning them out with saline, not giving them just packed red cells. And acidosis, when you're in shock, you're going to be acidotic, and we need to address this. Massive transfusion protocols aim to address by replacing clotting factors in addition to packed red cells. Ideally, the ratio is 1 to 1 to 1. Some hospitals, it's 2 units of packed red cells to 1 to 1. You got packed red cells, plasma, platelets, some coolers you might get in hospitals, you might get cryoprecipitate. Again, how do you dose this stuff in children? Packed red cells, 10 cc's per kilo. Again, use your Braslo tape to estimate your weight. Platelets are about 5 to 10 cc's per kilo. Plasma is about 10 to 15. There's a common thread, use 10. If you remember 10 cc's per kilo, that can be any one of the blood products that you're administering to a kid. And then there's a little bit of immunohematology sort of stuff on the blood banking side of things. So we know ABO, and you know Rh positive and Rh negative. Those are the most clinically significant. So in blood cells, the O is considered the universal donor because it doesn't have A or B antigens. And then the Rh, which is Rh positive or Rh negative, tends to be the most immunogenic. In plasma, AB is the universal donor. However, only about 4% of people in the United States of blood donors are actually AB. So if we don't have AB plasma, A is better than B, and it can be used safely if AB is not available. Platelets, we don't necessarily worry about ABO compatibility, although if we can give compatible platelets, it will keep the platelet circulation going much longer and not get destroyed as quickly. Things to do. Obtain your type and screen ideally before you give blood products to kids. Try to use the Rh negative in females, and if you have to do an Rh positive in a female, pass it forward from referring hospital to receiving hospital, from receiving hospital to the OR to the ICU. You have 72 hours to give RhoGAM to a female. So if she got an Rh positive product, she truly needs the RhoGAM, you have a 72-hour window. And a lot of hospitals, depending on blood banking, are going to give Rh positive to the males empirically so that they save the Rh negative for the females. So I'm talking about all these products, which beckons the question, well, what about the use of whole blood? So there are pros and cons to the use of whole blood. It tends to have higher hemoglobin, plasma, and platelets per actual volume. There are less preservatives and less anticoagulants used. The cold storage may actually help the platelets be a little bit more hemostatic. It's a balanced product. You don't have to worry about making sure that you are hanging 1 to 1 to 1 or you have not given 7 units of packed red blood cells to your 1 unit of platelets. And because you're not switching out blood bags, there's less contamination risk. Cons, there's a risk of hemolysis in the non-O recipients. You still have the risk of RH sensitization depending on what's available. And the biggest issue with whole blood is there's storage requirements that may lead to increased waste. So, whole blood can be safe in kids, but a lot of institutions are not switching to whole blood and are still doing components. I get a lot of questions about what about TXA? And yes, we can use TXA in children. So what TXA does is it binds to plasminogen, blocking its ability to lyse the fibrin strands. So it is trying to keep the platelets or for the fibrin strands from breaking down. There's a lot of studies in the adult literature. There's not as many studies in the pediatric literature, but we're hoping that a multi-center study will be coming soon. It sort of got delayed with the pandemic, and hopefully the TikTok trial is going to be underway and starting to get us some evidence. Based on the systematic review and the shock consensus meeting, the committee recommends empiric TXA for kids. TXA needs to be given within 3 hours of injury. The dose is 15 milligrams per kilogram up to the maximum adult dose of a gram. So if I have spoken to some of my referring institutions when they're transferring me a trauma patient where we've initiated the TXA at the referring hospital, and then we've got the second TXA infusion ready to go when the kid hits the door. And then there's viscoelastic monitoring, which may or may not be available in your institution and in your trauma bay. This is a better job than our coagulation screens and tends to, if you have it readily available, will give you data fairly quickly. And it's gonna look at platelet number, fibrogen function, coagulation factor function, and really help guide what product needs to be done. It may aid in resuscitation and hemorrhagic shock. There is not enough data to say whether or not it aids in TXA administration in kids. So that sort of wraps up a whirlwind tour of hemorrhagic shock. Figure out the kid's weight. Don't drown them in crystalloid. Switch to your colloid quickly. Control your bleeding. Get yourself good access. And again, if you're giving an Rh positive product to a female, make sure you pass it forward to the next person caring for that patient to see if we have 72 hours to give that female ROGAM. So neurogenic shock is the sudden disruption of the sympathetic nervous system to the vascular smooth muscle. So the sympathetic nervous system causes the muscle to contract. Basically, you now have unopposed vagal tone, everything dilates, you have profound decrease in your systemic vascular resistance. It's seen in spinal cord injury, and it's most commonly seen in blunt cervical spine injury. What you get is you get the hypotension without reflex tachycardia, and that's the thing, is if you actually have abnormality in your vital signs, if you are low on volume, you are going to be hypotensive, but your body is going to be tachycardic, trying to circulate what's ever left in the vasculature around. In neurogenic shock, you're going to be hypotensive, but you're not going to have that reflex tachycardia. You can actually see bradyarrhythmias, and because you will see warm, flushed skin as opposed to cool, clamped down skin. This is hard to tease out. So you start with fluid resuscitation, but if you're truly dealing with neurogenic shock, you need to switch to vasopressors. And what you want is you want alpha-1 stimulation to get that constriction of that blood vessel and help that out. You can add beta support for cardiovascular function. Norepinephrine is sort of a go-to that helps both with the hypotension as well as any bradycardia. And again, if you have anybody in neurogenic shock or suspected neurogenic shock, don't forget cervical spine immobilization, since we see it in C-spine injuries. And then lastly, the other type of shock that we will see in trauma patients, and we see in pediatric trauma patients, is obstructive shock. And this is where we have obstruction of blood flow into the heart, and we either see it with tension pneumothorax or with cardiac tamponade. Tension pneumothorax is where you get air in the pleural space, it accumulates, it becomes a one-way valve, and so then you have lung collapse, you have shifting of the mediastinum, you have compression of the great vessels, and you have decreased blood flow return to the right side of the heart. It is a clinical diagnosis. A tension pneumothorax should never be picked up on a chest x-ray. If you have absent breath sounds, if you have tracheal deviation, if you have any of those signs, you treat clinically, you needle the chest. If it is a pneumothorax and it's not a complete hemothorax, needling the chest, you're going to get a whoosh of air. You're going to see improvement in your breath sounds and in your vital signs, and time can wait for chest tube placement. And then cardiac tamponade, we don't see it often in children, though we can. And that's where you get blood accumulation around the pericardial sac. That compression limits venous return to the right atrium, which ultimately leads in decrease of the cardiac output. There is the triad where you have hypotension, you have muffled heart sounds, you have distended neck veins. Yeah, don't see that in every patient. The ultimate treatment is pericardiocentesis. In a child, we don't do those very often. The most recent patient that I had with cardiac tamponade, he was able to be maintained until he actually got to the OR. And there might be some friends in the audience who helped transport that kid to me. So whirlwind in pediatric shock, mostly hemorrhage, a little bit of other stuff. Does anybody have any questions?
So we did have a few questions sent in. One being, if children's vital signs are not a good indicator of shock index, does overall bleeding time factor in?
Does bleeding time factor in?
That's the question, yes.
Not really. Not really. You know, it's really, you have to use your clinical judgment, and you have to take, if you're at the scene, if you know the mechanism of injury, if you know how much blood was on the ground, if you know how much blood is on the floor, if we know that we've got extensive abdominal bruising in a serious motor vehicle accident, it's really taking all of that information into account in trying to decide which child is in hemorrhagic shock. You know, I certainly appreciate my first responders who bring in pictures of the scene, which help me sort of gauge, man, this was really a bad car accident, or letting me know how much blood was in the field.
And one other, do we need to consider pre-transfusion administration of calcium as we do in adults?
Not necessarily pre-transfusion, but I will give calcium if I'm sort of running a massive transfusion in my emergency department, and I have given significant amount of products. I will add calcium, a dose of calcium, but it's not necessarily needed for pre-transfusion. Thank you.
Can I?
Yes, sir.
Can I have a question?
Yes, sir. Yes, sir.
So we're talking about pediatrics. Mm-hmm. And one of the sad facts that came out this year is that firearm injuries is a leading cause of death in the pediatric age group. So this is along the lines of what you just went through. How do we prevent this?
It's a $1 million question.
What prevention strategies work in pediatrics?
Education. There are some studies that will show that a primary care provider who educates families and discusses firearms in part of their health maintenance, you know, as you're going through your car seats and your bike helmets and all of that stuff, and actually having an open conversation with families, that will help with, because it's really safe gun storage that we're talking about. Also in the emergency department, there are studies that show that safe gun storage, that discussions that we have with our patients will lead to safer gun storage. What we're doing at main campus at Rainbow, I have a grant. I have 1,000 gun trigger locks, and I am giving them away to my families and initiating these conversations. And that is trying to get that out into the community and have doctors talking with families who have children about safe gun storage.
Thank you for bringing that up. Do you ask every family that you're with that do they have a gun in the house?
If I don't, what I'm doing is I'm getting my residents to. I have two wonderful third-year residents, both going into emergency medicine, who are creating a curriculum to teach their pediatric colleagues, and we've also taught our emergency medicine colleagues the kinds of questions, how to bring it up, how to talk about it. So I have some residents who literally are getting into smoking in the home, you know, any marijuana use, do you have a gun in the home, do you have a trampoline,